Hello, and thank you for joining us for this presentation of What's All on 4 and What Isn't, sponsored by Russellville Dental Laboratory. We're available on the web at www.rdl-usa.com. To get started today, I want to establish some credibility for you, so I'll introduce myself. I am Lee Coursey. I'm third-generation managing partner of RDL. I, along with my father, Joe Coursey, who recently retired from day-to-day lab duties, have been restoring and lecturing about All on 4 for most of the last 10 years, and our lab has been restoring full arch implant cases since the early 1980s. We've restored several thousand of these All on 4 cases to this point, with clinicians and surgeons from Southern California to Northern Maine, and we're routinely chairside to assist with conversion in offices from Ohio to Tennessee and everywhere in between. We've also been through many of the same surgical training programs that you as surgeons and clinicians have been to or might be considering. But to really introduce All on 4, we really need to talk about the history. Back in the mid-2000s, Nobel Biocare started a revolution when promoting the concept of the All on 4 protocol. Alongside the revolution was some pretty heated debate because All on 4 violated some fairly well-established standards for implant dentistry, especially in regards to full arch restorations. Specifically, All on 4 did three things that independently were either questionable or just outright out there to many people. First, All on 4 used a minimal number of implants, as few as 4, instead of the maximum number of implants that could be placed in any arch. Prior to this protocol, we wanted to use at least 6 implants, but if we could use more, it was considered better. Second, All on 4 required the surgeon to remove, in many cases, several millimeters of bone before placing implants. Since maintaining bone is one of the most crucial elements of implant therapy, this was very nearly considered heresy. Third, All on 4 was an immediate load protocol, and immediate load was, and still is in some circles, hotly debated. It should be noted, though, that at the time this concept was brought to market, Nobel Biocare already had 10 years of documented success for the concept, and now we have close to 20 years with consistent results. However, beyond the changes in thought process when approaching full arch treatment, there were a few other frustrations that slowed adoption of the concept. First, Nobel Biocare also had a fully guided solution at the time that they launched around the same time called Teeth in a Day, and those dual protocols caused some confusion about which protocol was right for which patient, or even which elements of which protocol went with which protocol. Also, hybrids became synonymous with All on 4 to the point that at certain points in the history of this process, there was some confusion about whether the hybrid or the process of placing the implants was the All on 4 concept. And the name All on 4, let's be honest, has a number in it, which kept people focused on the number of implants instead of the complete protocol and caused a lot of confusion about what needed to be done to focus on All on 4. And to be honest, there were thousands of cases that were attempted without a clear understanding of the protocol requirements, which led to poor results and therefore a poor reputation in certain circles. But in order to really look at what All on 4 is, we need to compare it to something that is a known value. So let's compare to traditional full arch implant treatment. In traditional implant treatment, whether it was guided or not, the patient was evaluated for the maximum number of implants that could be we felt that could be successfully placed in an arch. We typically did extractions before implant surgery took place, and those extraction sites were allowed to heal. We might also have to do something like bone graft or sinus lifts to get more space to do the axial implants, which is what most everyone did at this time. And those long healing times between procedures meant that patients quite likely would go without a prosthetic for some period of time, and sometimes for extended periods of time. In comparison, if we look at the All on 4 protocol, the first thing that we do is establish the desired prosthetic outcome. That's the first piece of the puzzle completed. Second, extractions usually occur at the time of surgery, which reduces both the number of patient chairside appointments and the complexity of them. Also, no bone grafts or sinus lifts are employed. We avoid those completely by using tilted implants and angled abutments to achieve our desired prosthetic outcome and our desired anterior-posterior spread. And finally, the patient typically, although not every time, leaves with screw-retained teeth on the day of surgery rather than having to wait a period of time to have a prosthetic in the mouth. Oh, and it costs less than traditional methods, and therefore opens up full arch restorations for millions of patients that were priced out of the market before. So that's, in a nutshell, what All-on-4 is. But let's take a look quickly at what All-on-4 is not. The case that you see on the left-hand side of your screen is 4 axial loaded implants in the mandibular arch. This is not All-on-4. There are no angle-correcting abutments. There's no attempt to angle implants to maximize the AP spread. The case that you see on the right-hand side of your screen is a case that was done that was an attempt to be All-on-4, but was placed without the prosthetic outcome in mind, and therefore the implants are not in a position to ideally establish the prosthetic outcome that's desired. So if we are looking at what makes up an All-on-4 in kind of ideal circumstances, we see a couple of things. First of all, tilted implants along the in the maxillary arch, along the sinus wall, in the mandibular arch to avoid the nerve. We also see angled abutments or straight abutments, but abutments placed on every implant site that aren't removed at any point. These angled abutments allow us to improve the screw access hole position, and the straight implants allow us to have a uniform prosthetic implant platform across the arch. We also see a minimal number of implants. Although we see 4 implants in this scenario, it is not explicitly 4 implants that make an All-on-4. The concept is to do the minimal number of implants needed to achieve the outcome. Here we see that we have bone removed to support the prosthesis or the prosthetic outcome that we're trying to achieve. That way the final outcome is ideal for the patient, and the prosthetic platform or the implant planning achieves that. Also, we see a temporary prosthesis that the patient can leave and can be used as a backup prosthesis for a final restoration when that time comes. The core of the All-on-4 protocol can be defined in 3 stages: pre-surgical, surgical, and restorative. In the pre-surgical stage, the patient is evaluated for implants in much the same way any patient is. Since All-on-4 is not snake oil, it's not a one-size-fits-all concept, patients should be evaluated under several criteria. Emotional and financial needs are some of the most important. For many patients who undergo All-on-4, the number one most important thing is not having dentures at any point. Many of these same patients have avoided dentistry for fear of losing their remaining teeth and having dentures. Very few other protocols allow for as predictable treatment with screw-retained teeth at the time of surgery as All-on-4. After the patient is evaluated by the clinician, the surgeon, and the lab with CT and CBCT scan data and primary impressions, then we can tell them with a high degree of accuracy whether they're a candidate or not. Assuming the patient has agreed to the surgery and restoration and the associated cost, since this is fee-for-service dentistry, then we begin crafting the prosthetic that will serve as the baseline reference for the whole concept. The denture is created, and a clear duplicate, something we call a prosthetic guide, is fabricated to allow the surgeon to visualize the position of the implants in relationship to the prosthetic plan. We also provide a putty, not silicone, bite of the existing opposing arch against the new prosthesis to allow for getting the patient back to ideal occlusion as planned. During the surgical phase, the implants are placed according to the prosthetic plan, and then the denture is converted after implants have reached primary stability. No changes are made to the denture before this point, so that in case the primary stability is not reached, we're able to let the patient have the denture until the implants are stable enough to be provisionalized. No second denture is needed when using this method. No pre-drilled holes are made in the original denture before the time of surgery. In the restorative phase, after the patient has been released by the surgeon, the 4-stage method, as developed by RDL, is followed to allow for fast and efficient restorative visits. There are many restorative options for the All-on-4 concept now. Currently, milled zirconia structures are very popular for a variety of reasons. Most domestic labs in the U.S. today still don't process acrylic, so porcelain-style restorations are more comfortable for them. Further, most of the focus in our industry over the last 20 years has been on ceramics, so it's natural to look that direction because we've been conditioned to believe porcelain is better. Bar overdentures are also a common request. Many clinicians worry about hygiene at the last minute and therefore want something removable for cleaning purposes. A word of warning though, it usually takes more, not less, inner arch space to be able to restore a patient with a bar overdenture. Make sure this is discussed during the pre-surgical phase instead of after to make sure there's enough space. Malo bridges, or CM bridges, which consist of a titanium substructure with individually cemented crowns, are another option. However, cost is considerably higher due to the per crown plus bar pricing. In our opinion, and based on validated research, the best restoration for this type of protocol is still the milled titanium wraparound. These can be and are very aesthetic restorations in the hands of a skilled lab like RDL, and they provide a strong, stable core of titanium with the lower cost and easier repair of acrylic. Wraparound bars are typically reprocessed every 5 to 7 years, depending on the patient, and can be reprocessed with new teeth at a very reasonable cost if, for example, the patient wants a new restoration on the opposing arch. Although we at RDL have produced our fair share of full arch zirconia, we still find that for the money and the predictability, these acrylic restorations are the best investment. Remember, for many patients, financial considerations are a significant concern, so adding thousands of dollars to the cost of the procedure to go with porcelain may not be in their best interest. For more advanced treatment evaluation protocols, please consider Dr. Edward Bedrosian's work on full arch rehabilitation concepts. You can find this PDF you can download this PDF easily by Googling Nobel Biocare 73176 on any internet-connected device. We appreciate you taking the time to watch this video. Again, this has been a presentation of Russellville Dental Lab. We are located in Russellville, Kentucky, and our website is www.rdl-usa.com. You can reach me, Lee Coursey, Managing Partner of Russellville Dental Lab, at my email address, lee@rdl-usa.com, with any questions that you might have. Thank you for taking the time to watch us, and please feel free to contact us with any questions you might have.